Hey, it's Jessica Namaso with WTF Health. What's the future of health? I'm talking to the who's who of health tech and healthcare innovation, and I'm back again, another special edition with our series sponsored by Wheel, our virtual care regulatory roundup. And so today's guest is Quinn Shean. Quinn is a telehealth thought leader. She is an advisor to the portfolio companies with Tusk Venture Partners. In addition to that, she also advises with the ATA, the American Telehealth Association, and she's the vice chair on the Uniform Law Commission's Committee on Telehealth. So Quinn, it's great to have you here.
Thank you, Jessica. It's great to be here.
Long
time watcher, first time panelist, I guess, or first time interviewee.
I love it, Quinn. And we'll hopefully the last time because we've got a lot going on in telehealth this year, especially on the policy side. And so we have to take a moment and thank our friends over there at Wheel for sponsoring this series. Like I said, the Virtual Care Regulatory Roundup. Wheel is the telehealth company that is powering virtual care in the industry. They provide companies with they need to launch and scale virtual care services, including the regulatory infrastructure to deliver high quality and compliant care. You guys can find out more about Wheel at wheel.com. But in the meantime, we're going to pick Quinn's brain about everything that has happened from a telehealth policy standpoint since the end of 2022 and into this first couple months of 2023. So Quinn, lots going on in this space and in two different ways here. So we had that Omnibus legislation that was passed by Congress that did some things. And then we have the public health emergency ending, and that's doing some other things. So where I want to start is kind of with what's different between those two pieces of regulatory oversight in terms of what's being covered by the omnibus legislation, what's being covered by the PHE. What has happened with those two pieces of guidance?
Great question, and it is confusing because there's multiple different pathways as to when certain flexibilities that were extended as part of the pandemic end. So just taking a step back to 3 years ago, which feels like 20 years ago, as soon as the PHE hit, Congress and the administration made a number of flexibilities to allow telehealth to be used where previously it would have been prohibited. So most notably was in the Medicare program, which previously restricted the use of telehealth unless the patients were in certain types of facilities and in certain geographic areas. So for all intents and purposes, prior to the pandemic, a Medicare patient was not really being able to be seen in their home. But there were lots of other flexibilities in addition to that were made as part of the pandemic, as part of the PHE starting 3 years ago. So the question is, now that the PHE is ending on May 11th, what does it look like on May 11th or May 12th? What telehealth services are going to remain and which ones end? So the intersection with the omnibus you mentioned is really important. And what that does is it extends a lot of the telehealth flexibilities to the end of 2024. It makes them no longer contingent on the end of the PHE. That's what the omnibus legislation that passed in December that you may or may not have heard about. And the extensions that are part of that legislation are, as I mentioned earlier, the Medicare patients are able to be seen in their home for mental health services where other things were made permanent. There no longer is a requirement for in-person exams. That's been something that a lot of stakeholders had concerns with using telehealth for behavioral health. And there was a requirement that there was a prior in-person exam. So that requirement has also been extended to 2024. The extension around the use of high deductible health plans for telehealth services also is extended to 2024, as well as the types of providers who can use Medicare, who can bill Medicare was also extended to 2024. So those flexibilities, those are some, but the main ones that are extended to that date. They're not tied to the PHE, which is a huge win for those in the telehealth community. But some things are going to end on May 11th, 2023. So we need either the administration or Congress to have action, or as I said, we will go back to the status quo. Most notably, the biggest change as of May 11th, 2023 is around the prescription of controlled substances via telehealth. So prior to the pandemic, the current law, which will become the current law on May 11th, was in order to prescribe a controlled substance to a patient, you had to have had an in-person exam generally
Okay.
speaking. During, oh, go ahead.
I was gonna say, I want to ask real quick, controlled substance, can you give me like kind of run through a little list of what those might be? Just in case, like, you know what I'm saying? So it's like,
Sure.
if
That's a
those
good
might
question.
be,
Sorry. Yeah. So controlled substances are things like Adderall, which have been in the news, a lot of medications used to treat anxiety and other mental health conditions. It can include the use of testosterone for gender affirming care. It can include the use of many treatments for opioid use disorder, buprenorphine being a main one that we hear a lot about in the news. So I would say those are kind of the more common use cases that we have seen. Stimulants generally, they're Schedule II. That's also kind of part of the controlled substance framework. So as I said, during the pandemic, the DEA said, I know we have this rule requiring an in-person exam. We are not going to enforce it during the pandemic to ensure people can get the care that they need. Without congressional action or additional action from the administration, which is likely forthcoming, that rule goes back into place.
on May
So
11th.
what has been for 3 years stops on May 11th.
Okay, so I'm glad I asked about the list of the controlled substances there, because honestly, testosterone, I did not realize that that was involved in this, but that's like a very interesting point, I think, for a lot of folks.
Yeah, another one that a lot of people is ketamine that
Oh.
escapes a lot. It's kind of been under the radar as well.
Yeah,
But the main
growing
one,
in popularity for anxiety and for other mental health applications there. So this is really interesting then. And so I feel like this is an area where a lot of folks, especially at the ATA, have been really, actively trying to influence policy around this, because there are a lot of patients, one way or another, we're going to be left in the lurch here. So I mean, do you have a sense, Quinn, of what's going to happen? Like, I mean, you said that there would be likely, policy forthcoming, but do you guys have any idea of what might be happening? Will it just simply be extended, or what kind of questions are being asked about how to handle this post May 11th? I'm curious if you're hearing any gossip over there.
Yeah, so I think it's been the $1 million question, but not only for the last 3 years, but I think probably for the last 12 or so. As part of the legislation, and just taking a step back, the Reinhart legislation, which prohibited the use of telemedicine to treat new patients with controlled substances, it had an exception, which was for a special registration process for the DEA to establish, to say, typically we require an in-person exam, but if you meet these registration requirements, you can use telemedicine. We've been waiting for that registration for over 10 years. And the allowance during the PHE just extended that timeline. So this is something that really the telehealth community generally has been looking for guidance on. And the question is now, with 83 days, what's going to happen? There's a few different options that the DEA can take in coming up with this new framework. We know there's a rule out there. I know a lot of people in the telehealth community. I don't know anybody that's seen it. And it's going to include the framework for what will be required for practitioners to prescribe controlled substances to new patients. But there's a lot of outstanding questions. What schedules will be allowed? Will they go schedule by schedule? Will they go drug by drug? Will they require anything specific of the physician or the prescriber? Is it going to apply to new patients as well as previous patients who've been treated this way throughout the pandemic? There is one thing we do know about it, and that is we know as a general policy matter that the administration has indicated they will continue to allow the prescribing of controlled substances for opioid use disorder, so for medication assisted treatment through telemedicine, which a lot of research and data has shown to be quite safe, effective, and really bridging access. So that's kind of what we think and know might be in it. I think there's also a procedural question. As I said, we're 80 days. So if I'm a telehealth provider who is prescribing controlled substances, what am I supposed to do on May 12th? Do I have to stop seeing these patients altogether? Do I have to refer them out? Is there going to be a ramp off period to wind down to make that continuity of care? We don't necessarily know. I think most likely it will be what's called an interim final rule, where the DEA will release the rule and say, this is the rule that's effective, today or immediately, and we're taking comments on it. And once we get the comments, we'll put a final rule out that might be different or the same as this. I'm hoping that there's going to be some discretion to allow, as I was saying, kind of the continuity of care and ensuring that people continue to have access to these really important medications where safe and appropriate.
Okay, I want to zoom out for a second here and look at this instance of talking about, legislation around the prescribing of controlled substances. And my question for you, Quinn, is are we going to end up looking at the way that we are handling this, or the way that legislators and the industry and investors and the startups and provider organizations and payers are handling this one little instance? Is this going to end up being like a case study for all sorts of other telehealth questions that are going to be coming down the pike as other types of legislation, expires? I mean, and specifically maybe even some of the stuff that you had mentioned because of that omnibus legislation that could just, 2 years from now, I mean, which will go by in the blink of an eye, that we'll be looking at this, the way we handled controlled substance, and either mirroring the process, or is this going to set us up, down the road for well, this is what we did here. I mean, what are your thoughts on that? Is this a case study that we're going to have to carry with us moving forward?
I mean, from my perspective, this is a case study on what not to do in terms of, how you're shaping policy or thinking about it. Listen, I think it's important continually for policymakers and regulators to be looking at data and seeing what's working and what's not. But having kind of temporary policies in place, as we're seeing with what's happening on the controlled substance front, can do a real disservice to a number of people. It can do disservice to providers to not know what they can do and how they're supposed to prescribe. It can do a disservice to patients, as we're seeing, who don't have the an understanding of what their continuity of care looks like, what their options are going to be like if this medication they've been relying on is going to be taken away. It does a disservice to payers who are trying to figure out on the long term what they are and aren't paying for. For investors, it doesn't provide the predictability to know if this is something they should, make capital investments or infrastructure investments. And this is the same with kind of legacy health systems on all types of technology. And so, one of the things when people ask me if I can wave my wand and develop policy, one of the things is is this future looking? Is this providing a framework of appropriate patient safety, guardrails, so that it doesn't have to be tweaked every time we make one or two technological innovations, that the spirit of what you're trying to do is there, and give that predictability and consistency so that we can invest in new technologies without fear, and new care delivery models, and get providers to use them without fear that it'll be taken away, in a year, or know that it'll be, subject every couple years to this winding down the clock. So it's a long way of saying I hope. It's a long way of saying I hope not, but I fear it will.
No, I appreciate you really painting a very vivid picture of how it impacts all of the stakeholders all along, and in a way that makes it really difficult to plan for any kind of long term. I mean, right now we're how many days from the PHE expiring, and then at the most here we've got 2 years under this omnibus legislation. So
yeah, to give some optimism, it's not, I hate this phrase because it's been said too much, the
what, optimism?
No, not optimism. The genie is people are the genie's not going back in the bottle. It's not, right? We have now had an experience with virtual care and with new technologies that has shown that providers, patients, payers, everybody along the spectrum wants this to remain a permanent part of the healthcare system. And I think as a general matter, policy is recognizing that digital health or virtual care is healthcare. And we are seeing less prescriptive regulation that's saying you can only do this under XYZ, that this is the exception to the rule. We're seeing less of that. So I am very bullish on virtual care being continued to be reimbursed, allowed. I'm just saying that, some of the ways in which that predictability is there, when you get to the nuance, isn't isn't what I would like, but I'm optimistic to the future.
Okay, good. You capture beautifully the sentiment with my audience as well. They're very optimistic and bullish on it. However,
Very
it's
much.
not
I'm not
going
trying
the way that they want it to go.
the
That little
genie
more
is the genie
predictability.
is not going back in the bottle
Oh,
at
that's
all.
better than the toothpaste not going back in the tube. I mean, I don't know. Those are like, let's leave those phrases in the pandemic. I don't. I want to ask a little bit, Quinn, because I know one of your areas of expertise is state policy as far as telehealth is concerned. And so I'd like to talk a little bit about that. And maybe if you could start us out by explaining just, some of the things that are, under the national kind of purview, and then what do the states get to weigh in on specifically? And what are the things that are keeping you up at night as far as that goes?
Yeah, so I think it's a good question, and a lot of attention obviously gets focused on Congress and what's happening on the federal landscape. But my mantra is always don't sleep on the states. So, states really regulate the practice of care as a general matter. What can I do when this new technology is available to me? What can I do? Can I use it? Who can use it? Can nurses use it or just physicians? Where do I need to be? Where does the patient need to be? How is it going to be paid for? All of those are questions that are, in large part dictated by the states. So, as I said, while Congress has been kicking the can down the road and keeping us on our toes till the last minute, the states are passing legislation. I think nearly every state since the PHE was declared has passed a piece of legislation related to telehealth and touching on one of those topics. So, I think it's something to just kind of always be mindful of. It's again, what technologies can I use? Licensure questions, I'm sure, is of tons of relevance. Do I need to be licensed where the patient is? In what circumstances not? What can I be paid for? And one interesting fact that I looked up ahead of this, every 2 years, all the state legislatures are in session. That's where we are right now. 2 years ago at this point, there were 150 pieces of telehealth legislation. Right now, we have 450.
Oh.
Yeah, so in 2018, we're looking at that time frame, 2018, 2019, there were about 50. So
Oh my God.
pieces of legislation that are touching. So we are going up 300% every 2 years, which again, to speak to the optimism I'm talking about before, like it is no longer the exception. It is how are we integrating this care setting, because that's what I believe digital health is, a care setting or a tool, into our healthcare ecosystem. And that means it's on top of legislators' mind. So, that is something, that volume is something to pay attention to, but to also be interested and excited about.
All right. What is keeping you up at night when it comes to that? Is there any particular question that's being wrestled around there at the state level that you're like, oh my God, I mean, all of these startups over there at Tusk Venture Partners, you guys all need to be thinking about this. What's the thing? Quinn, scare us.
I know nothing. I mean, I think there's positive things to be thinking about. I think the licensure discussion is really interesting at the states. And states are thinking about more ways. If you only conceptualize telehealth as just, what can we do in the same ways that we can do with brick and mortar care, you're really going to limit its reach, right? And so if we're going to use telehealth or other types of digital health technologies to their full potential, it means, for example, accessing workforce resources in a different part of the country that can serve patients. So, how are we tackling kind of those barriers that are inhibiting growth and standing in the way? And if they're not clinically necessary, sometimes they're clinically necessary, a lot of times they aren't. So I think what keeps me up at night is when well-intentioned policy, I'll give an example. If you want to be, you're setting up a regulatory framework for telehealth, and then you say you can only use audio video technology, right? And we have this new telehealth framework and it's going to do all these great things and you can only use audio video technology. Well, that's not going to really serve some of the patients who are in areas who don't have the broadband tools to support that type of technology. And so while you might be well-intentioned in developing a policy of like, let's use telehealth and bridge access, you're cutting out a lot of the patients who would be most beneficial, right? And people in rural areas, people in cities who might not be able to afford that type of technology, but can't take off time work. So I think, generally I would say it's the clinically unnecessary barriers that, as a general matter, keep me frustrated. Lots of other things, but I would say that's probably the primary one.
That's the one. All right, we'll end it on that famous Quinn Shean optimism that we've come to know and love here in this episode. Hey, and end us on a high note. So what has you kind of most encouraged as you look, and let's look past the PHE in May, but let's look if we're having this conversation again in Q1 of next year of 2024, what has you most excited about the year ahead in terms of what could shape where we end up?
Yeah, and I've spent even pre-PHE a lot of times talking to policymakers, regulators about the value of new technology and better enabling care and reaching new access points and new patients. I'm a really big believer in that. The experience of the PHE, and as a lot of people have said, the silver lining was that people were able to, for the first time, use these new technologies and like the experience. And maybe they didn't like it for everything, but they liked it for some things.
Sure.
And having legislators and regulators who have now experienced these technologies has been the game changer in terms of making sure it becomes part of the future. Because before we were just talking about something theoretical, and now having had it and knowing that they like it means that it's going to stay in part of our fabric. So the biggest part is the end result of this is that we're seeing more and more policy that is treating virtual care and digital health as health, and just saying, if you're using this, we expect you to meet the same standards that you would, in any other care setting. But in doing so, we are opening up way new pathways for access, which is something that gets me excited about.
Oh, cool. Well, thanks so much for joining us here, Quinn. It was a pleasure to talk with you. And thank you again for walking through the difference between the PHE ending and the Omnibus legislation that was passed at the end of last year, and kind of what that means in different ways. I really appreciate your perspective on this. I mean, telehealth thought leader, there aren't very many out there. So it's good to hear from you. And it's good to hear from that attorney side / policy wonk side too. So I really appreciate it. Thanks so much.
Thank you for having me.
All right. Well, this conversation was part of our special series about virtual care and all the things that are changing as far as the regulatory and policy environment there. So if you want to catch the rest of these, they're up on my YouTube channel. That's youtube.com/WTF Health. Thanks again to our sponsors of this series, Wheel, Virtual Care Regulatory Roundup. We'll catch you on the next episode. Thanks so much. Bye.